To begin, let us acknowledge that Queen's University is situated on traditional Anishinaabe and Haudenosaunee territory. We are grateful to be able to live, learn, and play on these lands. We thank the Indigenous peoples of this area for the care of this land for thousands of years, and we hope to honor and respect them as we hold our virtual event today. I'd also like to take a moment to thank everyone for joining our presentation today. Our speaker this afternoon is Dr. Elizabeth Stringer, who will be presenting on pediatric Lyme arthritis, the next wave of Lyme disease in children. Dr. Stringer is an associate professor of pediatrics and medicine at Dalhousie University in Halifax, Nova Scotia. She is a pediatric rheumatologist and clinical researcher at IWK Health, the tertiary care pediatric hospital for the Maritime Provinces. Dr. Stringer completed her medical training in pediatric residency at Dalhousie University, followed by 3 years in Toronto, completing her pediatric rheumatology fellowship and a master's degree in clinical epidemiology. Dr. Stringer joined the Division of Pediatric Rheumatology in 2008. Dr. Stringer's interest in Lyme disease began early in her career when the Pediatric Rheumatology Clinic at IWK Health Center began seeing increasing numbers of children with Lyme arthritis. She published a study describing the clinic's early observations of outcomes of Lyme arthritis. Her present work involves collaboration with orthopedic, infectious disease, and microbiology colleagues aimed at early diagnosis of Lyme arthritis, particularly differentiating Lyme arthritis from septic arthritis. Dr. Stringer is also the principal investigator for the Nova Scotia arm of several studies within the Clydern network. We will have Dr. Stringer present, and then we will open up for questions from the audience. You can ask your questions by entering them into the chat box, raising your hand using the icon, or if an opportunity allows, unmiking and asking your questions. Please help us welcome Dr. Stringer to the podium.
All right, thank you so much, Veronica. And I'm assuming everyone can see my slides, hear me and see me.
Yes, we can. Everything's good.
Okay, perfect. So first of all, thank you for the warm welcome, and thank you to the Clydern Network for inviting me to speak today during Lyme Awareness Month. I'm looking forward to sharing some of our experiences in pediatric rheumatology in Nova Scotia regarding the impact of Lyme disease in children in the Maritimes and specifically Nova Scotia. So first of all, I don't have anything specific to disclose from a financial standpoint. I will disclose that I have a niche interest in Lyme disease, in that I only see children, and specifically with pediatric Lyme arthritis. And while I'm very involved with the Clydern Network and the PI for some studies, I haven't actually seen an adult patient in my practice for a couple of decades. Secondly, my other disclaimer is that I will probably shamelessly plug the Maritimes as a beautiful place to live, as well as a great place to visit. And here are some pictures from Nova Scotia. You'll recognize the Peggy's Cove Lighthouse, one of our many beautiful beaches, and an aerial shot of Halifax, which is where I'm located. So I have 3 objectives for today. So first, I'm hoping to paint a picture of what I consider a rapidly rising number of children with Lyme arthritis that we're seeing in our clinic. And I would surmise that these numbers will continue to stay high and potentially even increase moving forward, as that's our impression of what we've been seeing. I'll describe some of our experience in a tertiary care center in our pediatric clinic, diagnosing and treating pediatric Lyme arthritis. And also, as with everything that's new to someone's clinical practice, we begin to see some diagnostic and treatment challenges that I want to highlight as well. So the outline of the talk today will actually take us first back to what I call the origin story, or at least one of the origin stories of Lyme disease, and how it relates to rheumatology. I have a 10-year-old son who really loves the Marvel comic universe. And so every villain and every hero usually has an origin story. So I'm going to take you back to the beginning. I am going to discuss how children with Lyme arthritis typically present, describe our experience to date in our clinic, and then highlight a few diagnostic and treatment conundrums in pediatric Lyme arthritis. So just a little background on me and my practice. So I'm a pediatric rheumatologist, and I've been at the IWK Health Center since 2008. Pediatric rheumatology is a fairly small and new specialty, and there's only about 60 of us in the country, and 4 of us that work at the IWK, and we are the only pediatric rheumatologists for the Maritime provinces. I only saw one patient with Lyme arthritis prior to coming to Halifax, and that was during my fellowship in Toronto. And I actually missed the diagnosis, so it will be forever burnt in my memory. And the patient had actually traveled to New England, which was part of the history that I didn't get on the initial consultation. And so in 2013, about 5 years after being here, myself and my colleagues began to notice an uptick in the number of children being referred to rheumatology with arthritis, which eventually turned out to be Lyme arthritis. And at that time, I really started to develop a clinical interest, and then which led to research questions. And then ultimately, somewhat in a roundabout way, I ended up becoming the principal investigator of the Nova Scotia arm of the Clydern studies and some other studies in 2020. The original PI was Dr. Todd Hatchett, and COVID hit. And then basically all infectious disease doctors were pretty much tied up with COVID, and probably still are to some extent. And so I became the PI, and I've been working with a wonderful team here in Halifax to move those studies forward. So as of this month, I would estimate that we've seen about 200 children with Lyme arthritis probably over the past 10 years, but the bulk over the past 5 years or so. And one of the main messages is that the majority of children with Lyme arthritis actually have excellent outcomes. And I will dive into this a little bit more later on. So just again to highlight that the IWK Health Center is a tertiary care pediatric center. It's a standalone pediatric and obstetrics gynecology hospital, and we're located in Halifax, and we serve all of the Maritime provinces. So there's a wide geographic catchment of children that are referred to the rheumatology clinic. We do some outreach clinics in New Brunswick and PEI. In fact, I just came home from one this morning in Fredericton. And I just wanted to also show a picture of Lunenburg, Nova Scotia. So this is a beautiful fishing town where the Clydern studies that I'm working on are being set up. This is a picture of Fisherman Memorial Hospital, which is it's a hospital where we'll be recruiting patients, and we have our little research office. So we're going to go to the origin story. And again, I say one of the origin stories because I'm sure there were many pieces to this puzzle, but this puzzle particularly fascinates me because of its connection to pediatric rheumatology. So you can see here, there's a sign for the town of Lyme. So Lyme is in Connecticut, and the picture on the right is an aerial picture of old Lyme, Connecticut. And so it was in 1978 that this gentleman, Dr. Alan Steer, was a postdoctoral fellow. He is a rheumatologist. And he published this study called Lyme Arthritis, an epidemic of oligoarticular arthritis in children and adults in 3 Connecticut communities. And I have actually had the privilege to hear the story from Dr. Steer himself. I've seen him speak a few times, and I've also met him a few times, and he's a very interesting and kind person. And so what happened was in 1975, there was what we would, I guess, call an epidemic of juvenile rheumatoid arthritis. So juvenile rheumatoid arthritis is now actually called juvenile idiopathic arthritis, and it would be the most common condition that a pediatric rheumatologist would see in their practice. And so it is an autoimmune disease, and typically shouldn't sort of be diagnosed in clusters. And so it was in 1975 in November, there was actually a mother who called the health state department to say that 12 children were diagnosed with JRA in her neighborhood. And this was in one of the communities that's shown in this map, which is Old Lyme, Lyme, and East Haddam. A month later, it was another mother who called the Yale Rheumatology Department to say that her whole family had been diagnosed with arthritis, as well as several neighbors. And all the children that were diagnosed were also felt to have JRA, or now we call it JIA. So as I mentioned, juvenile idiopathic arthritis, which is the bulk of my practice, is the most common chronic rheumatic disease of childhood, with a prevalence of about 1 in 1,000. So it's rare, but more common, I think, than people realize. We don't know the etiology of JIA, hence the term idiopathic, but fundamentally, we know it is an autoimmune disease, so a condition in which the body's immune system turns on itself, and specifically, in this case, the lining of the joint, which is called the synovium. The average age of onset of JIA is 7 years. And within JIA, there are many different subtypes, but about half of the children, when they first seek medical attention, will have 4 or less joints affected, and very commonly knees or ankles. And we call this oligoarticular JIA. The remainder of the children would have polyarticular JIA, which means 5 or more joints that could be affected. And these children may present with up to 20 or 30 inflamed joints. There's no cure for JIA at present, but we do have many treatments that are available to us that can get this condition under control. Having said that, this is a lifelong condition, and many children with JIA will still require medications well into adulthood, and do not outgrow this condition as once was perceived. So when these 20 children or so initially were diagnosed with JRA, all in the same area, in a very low populated area, this seemed strange based on what was known about JRA. So a surveillance system was organized, and this was headed, I believe, by Dr. Steer. And over basically through word of mouth and talking to healthcare providers in the community, they identified 51 residents who had experienced this acute onset of arthritis in the last few years or so. The majority of these residents were children, but as you can see, 12 adults were affected as well. Dr. Steer examined all of these patients and did blood tests as well as synovial biopsy. So that means they took a sample of the lining of the joint from some of these residents. So most of these residents reported a sudden onset of swelling in a knee or another large joint. Almost 70% were monoarticular. So that means a single joint was affected when it started. 30% were oligoarticular, so that's 4 or less joints, and only 1% were polyarticular, so 5 or more joints. What was really interesting was that these individuals had recurrent attacks of arthritis. So, for example, they would have a swollen knee for a week, and then it would go away. It might go away for a few months and then come back again. The median number of attacks that these individuals had was 3, but some had as many as 12 attacks over the course of the time until they were entered into the study. 50% had isolated joint symptoms, so that means only their joints were affected, and 50% had some other symptoms like some fever or malaise, muscle pain, or headache. When they did a little bit more investigation and asked for things that might have happened prior to the onset of these joint symptoms, they discovered that a quarter of them had a rash about 4 weeks prior to the onset of arthritis, with a range of 1 week to 24 weeks, so as long as 6 months before. And they described an annular rash with central clearing, particularly on an extremity, which we now know would be consistent with erythema migrans, but at that time was just more a curiosity in terms of how it could be connected. These patients also had previous history of multiple skin lesions, so what we would now know is disseminated Lyme disease. They also had features of potentially neuroborreliosis, having a fever, having headache or stiff neck, as well as Bell's palsy. And interestingly, the rash was much more common in adults than in children. When they asked about potential bites or insects, one person remembered being bitten by a tick of all 51 individuals. When they looked at the laboratory features in these patients, they found that they had a mild elevation of the erythrocyte sedimentation rate. So that is a marker in the blood that would show some systemic inflammation. And when they looked at the joint fluid, so when they took a needle and took some fluid out of the joints, they found that these patients had a median of 26,000 white blood cells. And normal would probably be 1,000 or 2,000. So this was in keeping with inflammation, but as high as 98,000, which actually gets to a point where we start to worry about other infections in addition to the possibility of Lyme arthritis. So at this point, they didn't know this was Lyme, so this was just their observation. And most of them were polymorphonuclear cells. So those are the type of cells that are initially drawn to a site of infection. So that was maybe another clue in this puzzle. When they were able to take a biopsy of the synovium from the joint, what it showed was synovial hypertrophy. So hypertrophy means increased growth or thickening, and the synovium, as I mentioned, is the lining of the joint. They showed increase in blood vessel growth, so that's vascular proliferation. And they also found that the immune system was attracted to this area and was infiltrating the synovium. So something was triggering the immune system to come to the joint and cause this inflammation. So when they looked at all of these factors together, despite the fact that these children had been diagnosed with JRA or JIA, there were a number of things that really didn't fit. So as I mentioned, the prevalence is estimated to be about 1 in 1,000, but when they accounted for the population in Connecticut that they were seeing, this would actually provide a prevalence of about 1 in 10 children, so 10%. In these patients, almost all of them had this limited arthritis presentation, so monoarticular or oligoarticular, whereas I said in JIA, 50% of children will have a polyarticular presentation. So this also didn't quite fit. Females are more affected than males in JIA, which I didn't mention, but in this case, females and males were affected equally. When they did the blood work, they didn't find any autoantibodies. So autoantibodies are antibodies produced against yourself, and those are relatively common in JIA. And in JIA, by definition, adults shouldn't get it. And in this case, 12 patients had it, or people had it. And then what was really clear was that there was a geographic, familial, and seasonal clustering. I didn't mention that these patients, these residents generally presented in the summer and fall. And so at that point, it was already known that infectious agents could be associated with arthritis, so other bacteria and viruses. And so based on the fact that these individuals were clustered in the same geographic area, but in a sparsely settled area, a heavily wooded area with a peak occurrence in summer months, and despite people in the same family being affected, there wasn't a close temporal relationship. So it didn't suggest that a virus or a bacteria was being transmitted to cause this infection. And so Dr. Steer and his colleagues concluded that Lyme arthritis named after where it was discovered or described, is thought to be a previously unrecognized clinical entity, the epidemiology of which suggests transmission by an arthropod vector. So I think that's a very interesting clinical story, and as I said, pertains to my interest as a pediatric rheumatologist. But it wasn't actually until 5 years later, and multiple different people were involved and other clinical manifestations of Lyme disease were being recognized. But it was in 1983 in the New England Journal of Medicine that it was finally recognized that it was a spirochete that could be grown from the blood and skin lesions of Erythema chronicum migrans that confirmed that this bacterium was causing Lyme disease. And you can see that one of the authors is Dr. Bergdorferi, and the Borrelia species that affects people in our region would be Borrelia burgdorferi. So I'm now going to switch gears to talk a little bit specifically about arthritis as a manifestation of Lyme disease in children. So you can see in the picture on the left, this boy has clearly quite a swollen ankle. And on the right here, you can see that the right knee in this patient is quite swollen. So typically when we see someone with a knee effusion, so be called, the fluid collects up here in what's called the suprapatellar pouch. And so you can see that the kneecap is quite obvious in this side, but in this side it's completely obliterated, which is basically a big sac up here kind of filled with fluid. You can also notice that this person is standing with their knee slightly bent. And that's because an inflamed joint is most comfortable in a bent position. So if I was examining this patient, if I was to flex or extend the knee joint, it would be quite painful at the end of range. And that would be, and the joint would also be warm. And so this would be consistent with inflammatory arthritis. So arthritis, so we're just taking it right back to the basics, is really a term just to describe inflammation in a joint. And the term arthritis is used in many different situations. And so Lyme arthritis is arthritis that is caused by an inflammatory response to the bacterium. And so it is an inflammatory arthritis. Inflammatory arthritis in itself is not a diagnosis, and it's actually just a sign of, something is causing inflammation. So just having a swollen joint does not mean you necessarily have Lyme disease. You could have juvenile arthritis. There are many other things on the list that it could be. And also to differentiate from osteoarthritis, which is more of a degenerative type of arthritis that might occur in older individuals or individuals who have injured joints before. And, we sometimes call this wear and tear of the joint. Of course, it's much more complicated than that, but that is not what Lyme arthritis is. So this is a picture depicting a joint. And if you imagine a knee joint, this would be the femur or the thigh bone, and this would be the tibia or the lower leg bone. On the normal side, you can see that you have the bone, and then you have this blue layer, which is cartilage, that provides a bit of cushion to the joint. And then this little narrow sort of red line is the synovial membrane. So this is a layer of specialized cells that produces fluid to lubricate the joint. And so there should always be a little bit of fluid in a joint. That's normal. In Lyme arthritis and other forms of inflammatory arthritis, what you have is an immune response that brings the inflammatory cells into the synovium and causes the synovium, as I mentioned, to hypertrophy. So it thickens, there's more blood vessels that form, the synovium produces more fluid, and that's why you get the swelling of the joint. And in this case, I put these little squiggles here because it was, in this case, would be Borrelia that has created this immune reaction. But this would be very similar to the same thing that's going on in a joint with an autoimmune type of arthritis. You just wouldn't have any bacteria as the trigger. So I've taken some slides from Public Health Agency of Canada and tried to depict sort of the arthritis as a manifestation of Lyme disease and how common it is. So this is actually from 2009 to 2015, because I couldn't find similar more recent data. And this represents 1,600 individuals who had Lyme disease, and they've reported on all the symptoms that they might have had as part of their disease. And as you can see, erythema migrans is the most commonly reported manifestation, but arthritis was second, at least in this population, at about a third of patients. So what I find very interesting about Lyme disease is that children are actually one of the higher risk groups for acquiring Lyme disease. In addition, the older population between 55 and 79 years of age also has a higher risk, in fact, even higher than children. And I could speculate, at least for children, potentially, that there may be some behavioral or environmental factors that would lead to this, such as them playing outside and potentially, not necessarily being able to do their own tick checks if their parents aren't doing them. But there may be other factors, such as immunologic factors at play. Secondly, what I find really interesting as well is that if you look at the manifestations by age group, children, which is highlighted here in this blue peak, this is arthritis. Children are affected by arthritis more than any other age group. And why that is, I think, is unknown, but I think is very interesting. So not only are children at high risk of acquiring Lyme disease, Lyme arthritis is a common presentation above that of adults. So as I mentioned, in 2013, we decided to just have a look at the patients that we would seen to date. And this was done by a pediatric resident, Dr. Pierre Glaude, who was working with me, and then my rheumatology colleagues, as well as Dr. Mailman, who is an infectious disease doctor. And we actually only had 17 patients at that time. And this slide I created just to depict the increase in the number of patients that we've seen over time. So this was the 17 patients that were published in 2013, and that represented about 5 years. And I should say that we have a clinical database in which we enter diagnoses, and that's how we would find these patients. And then in the last 8 years, I would estimate that we've seen somewhere between 175 and 200 additional patients. I think it's an underestimate because through the COVID pandemic, things were less organized, and I don't think we were entering data into our database as consistently. The other thing I should mention is that these are only children that we see in pediatric rheumatology. There are likely other children in other parts of the Maritimes who may be treated by their pediatrician or family doctor and never come to see us. So this is an underestimation of the children that are affected, but you can imagine in our clinic going from just a handful a year to maybe 10 to 20 per year is a big change in our practice. So, is it unexpected that we would see so many patients? Probably not, given that Nova Scotia has the highest incidence of Lyme disease in the country. So in absolute numbers, we have less cases than Ontario, at least by report. But we do have the highest incidence of greater than 8 per 100,000 population. When we drill down a little bit more into Lyme disease risk areas in Nova Scotia, this is the most recent map that I could find. And you can see here that Nova Scotia is broken up into different counties, but there is a group of regions called the Western Zone, and that includes Lunenburg. And the incidence is estimated to be 320 cases per 100,000, and I believe that is the highest incidence by far in Canada. And so 10 years ago, this map actually looked a lot different. There were some areas that were considered endemic, but essentially our whole province is considered endemic at this point, with Cape Breton potentially being a little less at risk. So When a child comes in with what might be Lyme arthritis, they can present in a few different ways. So there are really two presentations that I think of that kind of are important to distinguish. So the first one is what we call an acute presentation. So this would be a child that develops swelling in a joint and comes in on the first day or the second day of swelling. And then there's another group of patients who have more the chronic or remitting presentation, where they've actually had a couple days of swelling or a week, and then it went away. They didn't seek medical attention, but then it swells up again 2 months later, and it can come and go, or they may be more chronic, so just to get swollen and it stays swollen. Typically, the ones that are acute will have more pain. Sometimes will have fever. And that is what brings them in typically to the emergency department, whereas the chronic or remitting ones might see their family doctor first. So the acute presentation is unique in that one of the other things that this diagnosis can be when a child presents is septic arthritis. So septic arthritis is also an infection in the joint, but would be from other bacteria such as Staphylococcus or Streptococcus, and is actually what we would almost consider a medical emergency. So a septic arthritis can be rapidly destructive to a joint within the matter of probably hours to days. And so it's critical that this is recognized early to avoid long-term damage to a joint. This could well be Lyme arthritis. It could be juvenile arthritis, but this is the one that we have to rule out. The patients that come with this chronic or remitting course are much less likely to be septic arthritis. The septic arthritis typically just doesn't behave that way. So I'm going to just present a representative case. This is not a single patient, but sort of an amalgamation of a few patients. And so this would be an example of an acute presentation. So this is a 10-year-old boy from Kentville, Nova Scotia. So that's a community in the Western Zone. And one morning he woke up in December with a painful knee. This progressed over 2 days to become quite swollen. He wasn't able to weight bear and a fever developed. He had no known history of being bitten by a tick. He had no history of ever having a rash that looked like EM or any other rash like cellulitis or anything that came to mind, and no previous history of a flu-like illness, really nothing. So this was really his first presentation of what is ultimately going to be Lyme disease, but we don't know that at this point. So in these cases, these children are usually assessed by orthopedic surgery because these are the doctors that need to manage a septic arthritis, if that should be the case. There are a number of investigations that we would typically do, and they can give us hints as to whether this could be a septic arthritis versus another type of arthritis. Again, the big issue is to consider septic arthritis and rule it in or rule it out. So this patient had a normal blood count, but did have elevation of the ESR, which I've mentioned before, and the CRP. So those are markers of systemic inflammation. So that suggests that there's inflammation going on in the body in addition to just the joint. And in this case, because of the concern of a septic joint, the next investigation that's needed is a tap of the joint. So you stick a needle in the joint and you take out the fluid, and then you look at the characteristics of that fluid. So in this case, the TNC count, which is the same as the white blood cell count, was over 100,000. So that is quite high and is suspicious for a septic joint, and 94% neutrophils, again, suspicious for a septic joint. Of course, we would also draw Lyme serology, but that is not going to be available for at least a few days. And so when this child is in the emergency department and orthopedics is assessing them, they have to decide, could this be a septic arthritis? And if there is even a chance that it is, we really need to manage it as such. Whereas if this was Lyme arthritis, a child could be given oral antibiotics, which I'll discuss in a few moments. So what has to happen to this child is that he is taken to the operating room, and orthopedics will do an incision and drainage, or I&D, in which they open up the joint, take out the fluid, and wash out the joint. They would be started on IV antibiotics for a possible septic joint. And then we would wait to see how the child does and also wait for the Lyme serology. So in this case, the child's Lyme serology was positive at 48 hours. Now in Nova Scotia, we're now doing the modified two-tier testing, which actually is done locally, and we get a result back quite quickly. In the past, when we did the standardized two-tier testing, we would sometimes wait a few days for the ELISA, and then it would be several weeks until we got the Western blot back. And so that was that could also delay the diagnosis. So this patient would have been transitioned to doxycycline, which is the appropriate treatment. And then in rheumatology, we are following up all the patients that come through the IWK with a diagnosis of Lyme arthritis for their follow-up to see if they've had resolution. And in this case, the child had full resolution of the symptoms of arthritis and the physical exam signs of arthritis, and was also systemically well. And I do make a point of asking about any change in behavior, headache, brain fog, school performance, and typically in all cases, I would say almost all cases, we don't hear of that. So I'm just going to present our 17 patients, and I think things have changed, and we will confirm that when we do a review of all of the rest of our patients. But when we first when we first reported these patients, we did notice that the bulk were seen just before we published the paper. The mean age of presentation was 11 years of age. And interestingly, 16 of 17 were male. That was really interesting to us in that we weren't sure what to make of it. One of the thoughts, which, sort of made me sad, was that potentially boys were outside playing more than girls. Maybe there was an immunologic basis to that, but over the years, we have definitely been seeing girls affected as well, although I don't know the exact ratio. All of the children that we saw were living in the known endemic areas at the time. Almost all the patients were referred, not surprisingly, for joint pain or swelling. And just like Dr. Steer's original paper, 50% had episodic symptoms and 50% were persistent. So when they have the episodic symptoms, that's a real clue that this is likely Lyme arthritis over juvenile arthritis, and also not septic arthritis. At that time, family doctors were the doctors referring the most, but we also got patients from the emergency department, orthopedics, and even the infectious disease service. And based on the referring information at the time, we estimated that 1/3 of the physicians considered Lyme arthritis as a possibility as the cause of arthritis. And this was based on whether they had already ordered Lyme serology or potentially had mentioned something about Lyme disease in the referral letter. When we looked at the season of initial joint symptoms, you can see here that between winter, spring, and summer, it's fairly equal. This is only 17 patients, of course, and the fall had sort of the least number. But one of the things back then that we heard sometimes from healthcare providers was that if a child presented with Lyme arthritis in the wintertime, for example, they didn't understand how that could be Lyme disease because ticks are not out in the wintertime. And so that was a misconception. And as we know, Lyme arthritis is a late manifestation of Lyme disease, and it's actually quite typical for us to see these patients in the late fall and winter. 3/4 of these patients had arthritis as their first symptom of Lyme disease. 3/4 did not recall a tick bite. And over time, I actually think this is even less. I would say maybe 5% of patients recall being bitten by a tick. Some remember a tick being around at some point, but most of them do not remember picking off an engorged tick. Only 3 of these children had something on history that suggested that they had had erythema migrans that wasn't treated or wasn't recognized, or they didn't seek medical attention for. And the median time of symptoms was about 2 months, with a range of almost immediate medical attention to 11 months. Most of these patients had oligoarthritis, and the majority had a monoarthritis, and almost all of them had a knee that was involved. But I've used this picture to show that while the knee is the most common joint involved by far, we have seen arthritis in all of the joints depicted here. So wrists, little finger joints, temporomandibular joint, shoulder, elbow, but knee is almost always included as one of the joints. Some of these patients did have flu-like symptoms that were reported, or either at the presentation of the arthritis or in the past. And interestingly, a number of patients actually presumably had neuroborreliosis that had not been recognized, and these patients had actually been seen by physicians. So 2 had had a facial nerve palsy, 2 had actually had meningitis, and there was a couple other neurologic findings, and these were not recognized as being attributable to Lyme disease and therefore not treated as such. We had 1 patient with eye involvement, and we had no patients with cardiac involvement. So when we look at our treatment, so we always treat with a single course of oral antibiotics to begin with, and we use amoxicillin for children 7 or under and doxycycline for those over 7. A few patients got ceftriaxone to start with because they actually had neuroborreliosis that hadn't been recognized. And so the majority of patients just got a single course of treatment, which is seen here, so 28 days. About 30% got more than 28 days, with the majority having 2 courses of antibiotics. And then 3 patients actually had what we would call almost like 3 courses of antibiotics, which consisted of either IV ceftriaxone or oral antibiotics. Now, in the patients that have a more complicated course, so the ones that don't respond after 28 days, we almost always have infectious diseases involved, and we co-manage these patients. But even amongst the infectious disease doctors and the pediatric rheumatologists, even within our center, we have slightly different approaches to treatment. And so that's, I think, partly because how we treat Lyme arthritis is not actually known in all cases, or we don't have a lot of evidence behind it. So I think the initial treatment for Lyme arthritis is pretty straightforward, at least in North America. So we would treat with 28 days of oral antibiotics, as I mentioned. So where it becomes a bit murkier is this idea of a partial response. So the child who has mild residual joint swelling, but really quite an improvement. And so in these children, there's no recommendation. So you can either observe them, so do nothing and just follow them up, or it wouldn't be unreasonable to give a second course of oral antibiotics. And so one of the challenges is, what constitutes a partial response? At what time point are we seeing these patients after their first course of antibiotics? Typically, we try to see them within a week or 2 of finishing the first 28-day course. But what I might think is a mild swelling, my colleague might feel is a bit more significant and may choose to give another course of oral antibiotics. Sometimes the parent wants another course of oral antibiotics. Sometimes they really don't want another course of antibiotics. So because there is limited evidence in these cases, I would present that to the family and we would make a decision together. My inclination is for the children who have a little bit of swelling left over is to just observe them and see them about a month later. And at that time, my experience has shown that the swelling by then has completely resolved. Then there's the group that after 28 days of oral antibiotics has no response or minimal response. And again, no response might be clear, minimal response, again, that's sort of a graded sort of thing. But in the present guidelines, it would suggest to use 2 to 4 weeks of IV ceftriaxone, and we typically would go with 4 weeks. Then there's the small group that have what's called post-antibiotic Lyme arthritis. So these are the children who have had a full course of antibiotics, but still have ongoing inflammation in their joint. And there's fairly good evidence to suggest that what starts as an infectious arthritis in this group of patients switches to more of an autoimmune form of arthritis, which is more similar to juvenile arthritis or an adult rheumatoid arthritis. And so at this point, we don't give more antibiotics, but we treat more to reduce the inflammation. So typically what we'll do, particularly like if it's a knee, which is the most common joint, is we do an intra-articular steroid injection. And that, in my experience, is very effective. Sometimes, very rarely, we'll have to use actual anti-rheumatic drugs that suppress the immune system that we use in our usual rheumatic diseases. And very occasionally, I think we've only had maybe one patient that ended up having a synovectomy. So that means actually going in and into the knee, and the orthopedic surgeon takes out that inflamed synovium. So when we looked at our patients, and this is again only 17 patients, we found that the majority had a complete resolution of their arthritis after a single course of antibiotics. About a third appeared to need 2 courses of antibiotics or even 3. And again, there is some treatment variation between physicians, but 2 of the 17 actually had refractory arthritis. So this means that we gave them at least 4 weeks of ceftriaxone in addition to their 4 weeks of oral doxycycline, and they still had inflammation. And so these patients would be in that category of post-antibiotic Lyme arthritis. We used to sometimes call it antibiotic refractory Lyme arthritis, which is probably a misnomer. And so So in terms of, why this 10% or whatever it is of the population goes on to have an autoimmune form of arthritis has been studied in detail. There are likely host factors, so factors about the individual's immune system, but also factors about the specific Borrelia species in a particular region. So we know that the Borrelia that we have in our region, Borrelia burgdorferi, is quite arthritogenic. So it does have a propensity to cause arthritis. So there's probably something about the different strains that may be more prone to causing this post-antibiotic Lyme arthritis. And this is a review that was published recently, again, by Alan Steer, which is a very thorough review of the topic. So I just have, I think, a few more slides, and then I'll be wrapping up. So in 2022, as of now, I have observed some things over the last little while, and these are just, I think are true, and hopefully with our further study of our population, we can confirm that. But I think I'm pretty sure that there is an increased awareness about Lyme disease as a cause of arthritis in children amongst healthcare providers, specifically in Nova Scotia. As I mentioned, we do get referrals from New Brunswick as well. My perception is that when we get children that are referred to us from providers in Nova Scotia, they often have already had their Lyme serology performed. And so obviously the referring doctor has considered this as a potential. In New Brunswick, I would say we often are calling those doctors before we see the patients to make sure that they've also ordered Lyme serology. And this may be because the incidence is lower in New Brunswick. I think children are coming to us faster, and there's less of a delay in diagnosis. In that those original 17 patients, there was a few patients that had had recurrent joint swelling over an entire year and it presented to medical attention, and no one had considered the diagnosis. I don't think we see that as much. I have not seen a diagnosis of what I would call missed neuroborreliosis in any patient that I know of in the last number of years. So we always do ask, did you have a Bell's palsy or some sort of neurologic manifestation prior to presentation? And that's not happening. So I think those children are being recognized appropriately. We've also seen that our orthopedic surgeons are taking fewer children to the OR for the IND procedure in favor of admission and potentially observation. So they are potentially seeing some clues in the kids that are coming in that makes them think septic arthritis is a little less likely and feel a little bit braver in terms of not taking them to the OR. And in most cases, and I think all cases, they actually are correct because we are just seeing so much Lyme arthritis. My observation is that most parents are aware about Lyme disease, but many know about it based on what they've read online and not necessarily pertaining to children. It's a lot about adult Lyme arthritis and sometimes the chronic symptoms of Lyme disease. That can be quite frightening for the family when they learn that their child has Lyme disease. And many really do not know that Lyme disease causes arthritis, and definitely not that it is a common presentation in children. Parents continue to be surprised by the diagnosis when they really don't recollect a tick having ever bitten their child. And many of the parents that we see do check their child every single day. And still, obviously, they're missing, not missing, but the tick is evading, I guess, their ability to see it. Ultimately, the outcome, in my experience, is that it's excellent for children with Lyme arthritis and the general health of children with Lyme arthritis. The alternative, in some cases, when these children present, is a diagnosis of juvenile arthritis, which is a long-term chronic disease. So when I see positive Lyme serology and I see these children, to me, that's actually in some ways good news, because I know the vast majority are going to respond to antibiotics and not have a lifelong disease like juvenile arthritis. So I mentioned that with seeing more patients, we're starting to see some unusual presentations, and we continue to have a number of clinical conundrums. So as I've already mentioned, what is the best treatment for the partial responder? What is the definition of a partial responder? Can we confidently exclude septic arthritis or rule in Lyme arthritis in children with acute presentations? And can we avoid those admissions to hospital and going to the operating room? There is a cost to both the child in terms of morbidity and potential complications, as well as to the health system. The other thing that we're running into is that we have children who have juvenile arthritis, and by definition, when they flare up, they get swollen joints. So for a child living in Nova Scotia, is this a flare-up of their juvenile arthritis, which needs more treatment for that, or is this Lyme arthritis? So we're starting to see that. We're also seeing some children who have potentially actually had erythema migrans in the past that's been treated, but then 2 years later, 3 years later, they come presenting with what appears to be Lyme arthritis. I saw a child last week who I treated for Lyme arthritis in 2020 and had a good response to antibiotics. The emergency department called me last week that he'd had a new onset of knee swelling, no fever, otherwise well. And I saw him a week later and the swelling had almost disappeared. So is that another episode of Lyme arthritis? Is it possible that it's recurrence of the initial episode? I don't know. Is it juvenile arthritis? We elected not to treat and just observe. And the mother was very happy with that decision. And so I'll see him in a few weeks' time. And then we've had these unusual patients in which a child, for example, would come in with a swollen knee, and we would treat with a month of doxycycline. The knee that was originally swollen responds or gets better and has resolution. And then the other knee swells up after they've already completed their course of antibiotics. So is that still their Lyme arthritis caused by the bacteria, even though it looks like the other knee has responded? Or is this an autoimmune phenomenon? So do we treat this with more antibiotics, or do we treat this with a steroid injection because we don't have any tests other than serology to rely on? And finally, what is the best treatment for post-antibiotic Lyme arthritis? There was a study from New England recently that suggested that you could inject the knee after a single course of antibiotics in conjunction with giving them a second course of antibiotics. We would normally wait until they completed their second course of antibiotics. So to answer some of these questions, we do have a number of projects that are ongoing. So I am collaborating with Todd Hatchett and orthopedics and ID at the IWK, where we're going to do a validation study on a near point of care test on stored serum samples. So could we use a point of care test in the emergency department that would confidently allow us to diagnose Lyme arthritis to prevent these children from going to the OR? We're also going to do a retrospective review of all the patients we've seen since our original study, as well as a systematic review of pediatric Lyme arthritis outcomes. And the other thing I'm interested in is getting a snapshot of how Lyme disease is impacting my colleagues across the country. I think at the moment, I think de facto, we are the experts in pediatric Lyme arthritis in Halifax by virtue of the fact that we've seen so many children. But I think this will only creep more and more into pediatric rheumatology practice moving forward. So hopefully we have gone over these objectives. So my first objective is not quite finished, but recognize that Lyme arthritis in children is clearly on the rise in Nova Scotia, and describe our experience and be aware of some of the challenges that we have in caring for these children. And thank you for your attention.
Thank you, Dr. Stringer, for your wonderful presentation. I'm just going to the chat box. I see a couple chats, a couple thanks. People had to pop off the call. Here is one. Did you try to culture knee aspirate? I think that would be a golden opportunity. And the individual is offering to help Dr. Morshed to culture knee aspirate if a patient did not get antibiotics prior, and can also offer PCR test as well. It would be a very important addition to serology.
Yeah, so the challenge, so we don't, yeah, so we, the opportunity to get synovial fluid is with the acute presentations, so the ones that present to orthopedics. And so, yes, that synovial fluid is a huge opportunity. And no, we have not cultured it today. We don't have the ability to culture in Halifax. Hopefully we will in the future. We do sometimes do Lyme PCR in the synovial fluid, but from my understanding, you know, in terms of the specificity or sensitivity, you know, these would be sometimes the patients who didn't respond, and we're wondering, you know, is it ongoing infection? But if it's negative, it doesn't necessarily absolutely rule out that there still could be bacteria there. And if it's positive, could that just be like remnants of the bacteria and not necessarily active infection? So I don't tend to use PCR in my clinical practice. But I think getting those samples from orthopedics would be fantastic, because that would be synovial fluid that has not yet seen any antibiotics. The challenge is that we would obviously have to develop a protocol and an REB for that, and fitting that into the emergency department and the logistics around that would be challenging, not impossible. And we've definitely have started to put some, I guess, plugs in place for the emergency department. And that was, you know, as far as we got, and then COVID happened. So yes, we would. I think that's a great suggestion.
Yeah, thank you, Elizabeth. I just wanted to let you know that we have a validated method, and we have validated like significant work we have done for clinical samples. So if you want, I can send you some transport media, and then whenever you get, or your orthopedic surgeon get, they just have to pour some fluid there and then cap it and send it to the room temperature. And I don't think you need ethics. It will be kind of patient diagnosis, basically. So you do not need any ethics. And in Canada, that is the struggle for last 25 years that I'm here, that we have so many Lyme cases serologically, but we do not have a single culture positive. So at least before I retire, I wanted to do one culture from human. So
Okay.
that is why I said that we can do for you if you want, or Todd can do there if Todd wants. I can help with the protocol and everything, but you have the golden opportunity in Nova Scotia. We don't. That's why I think it would be nice to work together on this.
Absolutely. Thanks,
So we'll
Marsha.
get you guys to connect offline and see what can happen in that area. Someone was able to put the link in from the Public Health Agency of Canada from the 2019 report, which summarizes data for 2009 to 2019 on the multi-year rate that summarized Lyme disease. So there are some updated figures as well. I'm not sure if that link also breaks it out for Lyme arthritis as well. I don't see any questions in the chat box, but I just have a question before I open up to the audience, wondering what your colleagues across this country are seeing in rates and instances of Lyme arthritis with children. I mean, recognizing that your population rate is a lot higher in Lyme in general, but I'm just wondering whether, you know, as you start to head west, you know, are they seeing similar increases in Lyme arthritis in children?
Yeah. So I have no idea. I've done some sort of informal polls of my colleagues in Ontario. And so I think one of my colleagues in Ottawa, he suggested they were seeing some more. I have a colleague in London, and they often call me when they have sort of clinical questions, just because, or one of my colleagues, because we've seen so many. The other thing is that, because we live in like our particular population, I guess, where we practice, the patients get referred to us, but I'm not sure necessarily if you're in Northern Ontario, or maybe that's not a good example, but I'm not sure about referral patterns. So who's treating these kids? And that's sort of why, does a pediatric rheumatologist need to see all children with Lyme arthritis? I mean, I don't know the answer to that. But that's why I want to sort of generate that survey to my colleagues. But then, of course, there's pediatricians, family doctors. There's all sorts of other ways that these children may be seeing doctors and healthcare providers. But I can only assume that it is going to be part of everyone's practice moving forward more and more. And we're just the people who happen to live in the area where it started.
Thank you. I do want to open up to the audience. If you have any questions for Dr. Stringer, feel free to raise your hand icon or unmute and ask a question. We can take a couple minutes just to answer questions before we wrap up today. Just looking to see. We have a quiet bunch today. Does anybody have a question for Dr. Stringer before we wrap up? I guess there's no questions from the audience. Well, I do want to thank you personally, Dr. Stringer, for your presentation and helping us walk through and navigate, especially the challenging terminology when you're talking about arthritis and all the joints and everything. I do want to remind you that our presentation series does continue tomorrow. Tomorrow we do have Dr. Richard Horowitz, who will be presenting the future of Lyme, tick-borne disease, and global health challenges in the 21st century. That presentation will start at noon tomorrow. So if you can join us, please join us. Also a reminder to take part in our challenge, wear green or wear a green face mask, take a photo and share it with us to help spread awareness for Lyme disease. You can also send in pictures of your art or creative work. It doesn't have to be an actual photo. All entries we received will be automatically entered into our draw of one of 4 $25 gift cards to Starbucks. And again, entries do get sent to clyden@gmail.com. Thank you again, everybody, for attending. Thank you again, Dr. Stringer, for your presentation. And I hope everybody has a great day and a great rest of your week this week. Take care, and hopefully we'll see you tomorrow.